Dr. Edwards, who is standing right behind me. Dr. Nilu Edwards was born in Sri Lanka. He is right now the head of thoracic and vascular surgery at St. Peter's Hospital. He went to school at Columbia in New York. He then did his that's medical school. He did a residency in surgery in Rochester, then went to Columbia Presbyteria for your cardiothoracic surgery fellowship. St. Peter's unfortunately stole him away from Wisconsin, where he was chief of cardiothoracic surgery, and now he remains chief of vascular and cardiac thoracic services at St. Peter's. So without further ado, I'm going to let Gio introduce Mr. Wilkie.
Okay.
Where are you? All right, there we go.
All right, Gary Wilkie's been a friend of mine for many, many, many years. He was not educated at any of the same schools that Dr. Edwards was, but it was a dark and stormy night when he was born in southern Averill Park, and he's a very, very good guy. He was diagnosed at the age of 36 with familial dilated cardiomyopathy. I get that right, Jackie? Super. All right, out of all of his siblings, there's one brother and one sister are deceased, and his father is also deceased from this same disease. One sister does not have it, and then a 37-year-old sister does, and she is also being monitored very closely. Out of all 5 children, there's only the one child from Mr. Wilkie's siblings that do not. He's got a couple of nephews that also have dilated cardiomyopathy. His family has been featured in 2 studies, one out of the Mayo Clinic, another one out of Boston. There's a geneticist that apparently found the gene that is activating this and causing the problems in his family, and they're working to try to figure out how to turn that off. But essentially what happens is his heart continues to expand and to grow to the point where the septum in the center of the 4 chambers of the heart becomes so stretched out and so weak that at Mr. Wilkie's worst, it was every 3rd beat was a perfusing beat. It took his heart 3 times before it built up enough pressure to push out enough to get any blood to the rest of his body. His heart was down to 3% when his Lvad was installed, which is within probably hours of death. His ejection fraction was about 10%. He worked for many years up until he was in his early 40s in the construction and petroleum industry, did mail delivery and things like that. Never had a heart attack, had an implanted defibrillator and pacemaker, was defibrillated 9 times over the course of his malady. The pacemaker he's had for about 10 years. Like I said, the heart is twice the size that it should be, and he was holding it about 20% for a long time. They were treating him pharmacologically and monitoring him very closely. His heart was holding at about 20%, and then rapidly over the last year is when things really started to take a nosedive, and that's when the Lvad became necessary. He went out to Boston and has a heartware, correct? Heartware installed that he's currently wearing. He's currently 1B on the transplant list, and we're very fortunate to have him here today. I guess a heartware patient, the longest known living patient on a heartware has been about 2.5 years. And Mr. Wilkie now has 1 year. You have a full year under your belt?
Just about.
Yeah, just about a full year. So, and that's it. He'll be up for any questions. And his wife Jackie is here with him. She's obviously one of the primary family members that's trained in this. But his primary family, his son and his daughter, are also well trained in what needs to be done. And pretty straightforward, pretty easy thing to do as far as managing that. It's not really as scary once you get your head wrapped around it as you think it would be. So, with that being said,
thank you. Thanks. I've divided this talk about ventricular assist devices into 4 parts. So the first part is really, before we talk about ventricular assist devices, we need to really talk about the treatment for heart failure and how this fits into that spectrum of stuff. The second is really to talk to you about a lot of different types of devices that are out there, because there are many devices out there, and I've divided them into sort of very broad categories so you can understand a little bit about how each of them play out. And some of them will impact you over the next few years as for transport purposes and things like that. Then we'll talk a little bit about the assist devices, putting them in, and then a little bit about when you put them in. And again, that's more just kind of FYI than anything else. So let's start off a little bit with with heart failure and why there's a need for some kind of treatment when you start developing heart failure. And this is a slide, and they say you shouldn't start with these graphs, but it's actually a good way to look at what happens if you've got heart disease. So people who have heart failure to the point where they need a heart transplant or an assist device, their survival is basically 80% of them dead in about 2 years. So and that's with best medical management. Over the years, we've seen a little bit of improvement, but you still see that 50% of them are dead about 5 years. So it's really treating patients with heart failure medically is limited in terms of what it can do. Which brings us to what is the gold standard for treating patients with heart failure. And for years, the concept has been, okay, if we can just replace the heart with another heart, that would be the way to do it. So the legend goes that St. Damien and Cosmos did the first transplanting the leg, a gangrenous leg from one person to another in 4 AD, and they just, by coincidence, happened to be the patron saints of medicine, so transplant and medicine kind of tie together for a long time. But it really wasn't until this guy, Alex Carrel, in the 1940s, who devised a way to sew one blood vessel to another, to do vascular anastomosis, and that's really what allowed us to start being able to do transplants per se. And then this man, Peter Medawar, was a immunologist who was working in Britain during World War II, and the RAF had a lot of burnt pilots, and they needed sort of to do skin transplants for them, and so he worked out the immunology of being able to do a transplant, to be able to take the skin from one person or one animal and put it on another without it being rejected. And so it's really the work of these two people that allowed this to sort of move forward. And then in the 1960s, Norman Shumway first started doing heart transplants at Stanford in a dog, and this is Ralphie, the first surviving heart transplant recipient. But in the late 60s, Christian Barnard happened to be working with Dick Lauer, who was the other person in that earlier picture, and he was in Virginia, and he was doing some other research there, and he happened to see Dick Lauer doing this transplant in a dog, and he kind of saw this, picked up the idea, went back to South Africa, and he did the first heart transplant in a human, which was in 1967, which is one of those kind of epic, for most of us of that generation, this was a huge, momentous event. And the sort of the question, and I always bring it up in this way because the question is, why didn't Shumway get the credit for it? Because he really is the one who did all the work. And the reason is, I don't have it here, the reason is because brain death laws didn't exist in the United States. So if you took an organ, a heart out of somebody who was brain dead, it was considered murder. And actually still in Queens, in the borough of Queens, New York, it has never been written off the books, even though federal law supersedes it. So it doesn't really matter, so that's why they couldn't take the organs from people who were brain dead in the 1960s. Of course, South Africa was a little less regulated, so it was a little easier to do that, and that's why the first heart transplant was done by Christian Barnard. But it's really the credit should go to Norm Shumway. I was at the University of Wisconsin where I was chair, as you heard, and these are the outcomes in Wisconsin. So if you were transplanted, with the transplant, I should say, your 1 year survival is about 83%, and it's actually now even better, it's about 85%. And your 5 year survival is in the high 70s, so about 78%. Now you got to compare that with medical management that I showed you earlier, where your survival curve looks like this. At 2 years, 80% of the people are dead. So that's the difference in survival that a transplant makes. So when I was in medical school, I was told there are 2 reasons to ever operate on somebody. One is you can improve their survival, and the second is you improve their quality of life. And clearly, transplant improves survival, but it also does amazing things for quality of life. And this is a young woman by the name of Maritza. And Maritza was before I went to Wisconsin, I ran the heart transplant program at Columbia. And she was a young woman that we transplanted in late 90s, about 98 or so. She had a congenital cardiac problem. And when you get to end-stage heart disease, this is what you look like. And this is in the days sort of before VADs got to the stage where they are right now. And you get this sort of wasting because your body can't digest food, and your gut is so swollen it won't absorb the calories you're eating. And this is kind of what she looked like. For those of you who worked in a surgery, you can see that actually she's already had a heart transplant, because surgeons are superstitious and we won't take photographs of people before their surgery just in case. So, and this is Maritza a year and a half later. So it's a huge difference in terms of quality of life. So even if we didn't make patients live longer, just in terms of quality of life, it's worth doing transplants. So that's the benchmark that we need to compare it to. So everything we do in terms of ventricular assist devices and any other treatment has to be compared to that, because that's the gold standard. But the problem is, what do you do with someone like this? So this is a 43-year-old gentleman who, again, this was when I was down at Columbia, who was transferred in from Long Island. They'd just done a bypass surgery, and if you look carefully, you can see that they had taken the veins from his legs here. And then they did the bypass and couldn't come off the heart-lung machine. And the question is, so what do you do with him? You can't really go out and find a donor right away and transplant him. And so you need something to bridge him to the point where he can be transplanted. And we'll talk a little bit about the indications in a minute. So that's what generated the whole interest in something other than transplant, because we need to bridge people to the point where they can get a transplant or an alternative to that, and we'll talk about that in a minute. So there are a number of different, technically there are a number of different assist devices out there. Probably the one that's been around the longest and the one that we know the most is the intra-aortic balloon pump. And some of you may or may not have had to transport people with this. Usually it's an intra-hospital transfer. The console's relatively small. The device is actually fairly easy to put in through the femoral artery. The upside of it is it's easy to manage, easy to insert. The downside is it only, every time the balloon inflates, it displaces blood. But the amount of blood it displaces is about 10%. So if you've got a 10% ejection fraction, with the balloon pump, it goes up to 11%. Doesn't do you much good. But it is a good temporizing thing. It's good for people with acute heart attack, myocardial infarctions. The second type of device is, and this is actually, it's a Spanish slide, but the pictures are good, is a centromag. And so the centromag is a type of device that sits outside the body, but the tubes are all connected inside. So you've got a tube that goes into the right atrium, brings blood out, and it then pumps it into the pulmonary artery. A tube that brings blood out of the left atrium and pumps it into the aorta. But the pumps themselves sit outside the body, so it kind of looks like this. This is the deoxygenated blood coming out of the right atrium, goes to the pump, comes back into the pulmonary artery, and then the oxygenated blood coming out of the left atrium and getting pumped into the aorta. And the whole device sits outside the body. So you got basically tubes coming out of the patient that are running blood into the pump and then circulated back into the patient. Advantage with these devices is they're very robust, they're good in the short term, but they're really short-term devices. They're really approved for only about 10 days. The gentleman I showed you with the heart attack would be a good sort of temporary bridge, but if you need somebody who's longer, we'll talk a little bit about that, that's a little bit more limited. The other advantage with these devices is that you can, if you go back, if we connect the deoxygenated blood with an oxygenator back into the arterial line, you wind up with what's called an ECMO circuit, which stands for extracorporeal membrane oxygenation. We've actually seen quite a bit of this and done quite a bit of these in the Albany area, not because of heart failure, but because of respiratory failure. So interestingly, I mean, you know, there was sort of a big, in probably about late 2000s, there was the whole H1N1 problem, right, where people were coming in with ARDS, respiratory failure from H1N1. Well, it didn't really go away. It's still around. Actually, last winter, we put in about 6 ECMO devices in patients because of respiratory failure. Usually they tend to be obese, they are on steroids, some other reason like that. But it's still, H1N1 is still out there and still causes respiratory issues. if you can bridge them to the point where, if you can support them to the point where their lungs recover from the injury, then you can actually get them through the sickness. But how do you do that? And the way we do it is with an ECMO circuit, which is basically a heart lung machine that you can connect to the patient. You can actually get them up and sitting up in bed, even with those tubes hanging out of them, until their lungs recover, which sometimes takes weeks, but you can support them through it. The survival isn't great, but they're usually younger patients, and it's worth doing. All right, so these are all the external devices: intra-aortic balloon pump, the ECMO circuit we talked about, tandem heart, which is sort of, these are Lvads that are inserted through the artery and the vein, and we'll talk a little bit about this later. I put this up because these are the ones that you may wind up at some point getting involved with if you're doing inter-hospital transfers. So intra-aortic balloon pumps, not an uncommon transfer. These two devices are starting to be used more and more in patients who need intra-aortic balloon pumps. So again, you might find yourself being involved with transporting these patients because they're being used instead of an intra-aortic balloon pump. ECMO tends to be more of a specialty thing, and it's unlikely to be transported, but not unusual. I mean, for example, St. Peter's has a relationship with Troy, and if we put one of these devices in Troy, we're going to have to ship them back to St. Peter's, and it's going to be an issue with transporting him. This device, you're unlikely to see. It has a very big console that sits about this high, usually won't fit in a rig, so it really will tend to be this and this. In Europe, they're using these for acute heart attacks much more than balloon pumps. So those are the sort of what we call paracorporeal or extracorporeal devices where the machine actually sits outside the body and the tubes are all connected inside. Then we come to the ones that are fully implantable, and I'm really going to just talk primarily about this, which is the HeartMate 2. This is kind of what the device looks like. It goes into the apex of the left ventricle. The pump is an axial flow pump, so it's sort of, no one ever paid attention in high school physics, but if you remember, there's a thing called an Archimedes screw, where if you turn a screw in a fluid, it'll make the fluid flow past it, and that's basically what a turbine is, and that's what this is. So you've got a spinning impeller, and when it spins, it forces the blood through into the aorta, and we'll come back to this in a minute because it ties into why CPR in somebody with an LVAD is kind of a moot point. It's not really going to work that well. So this is the sort of the current generation of assist devices. What Mr. Wilkie has is something called a Heartware, which is basically the same principle as this. The device is a little smaller and probably would fit in the cup of your hand. It's a little bit smaller type device, but the principle is the same and doesn't change anything that I'm saying. It's just, Ford versus Chevy. It's not really making a huge difference other than that. And lastly, in sort of the spectrum of assist devices is the total artificial heart. This is the one that's currently approved. Basically, you cut the whole heart out and you replace it with a pump that works for the left and right sides. Not something that you use in most patients, and I'll explain, well, I guess I'll explain it now. One of the downsides with this is if it fails, it's done. There's no backup system. One of the things with patients with devices like this is when it fails, and I'll tell you, actually I might as well tell you as I'm remembering them. Even if it fails, sometimes patients can survive because their native heart will still do some pumping, and it'll bridge them to the point where they can get to a hospital. I had a young woman who she was a little bit heavy, and she had a amputation of her leg for a cancer, which sort of created a little bit of a problem because the chemotherapy they used affected her heart. And this was, again, when I was in Wisconsin, so I get a phone call from the Beloit ambulance service saying that we have this woman that we're transporting. She was climbing a fence. And I'm sort of trying to think, a heavy young girl with an assist device, one leg climbing a fence, and she got her device drive line caught in the fence and snapped the drive line. So the machine stopped, and it's like, first I had to take a double take as to what she was doing on this fence in the first place, and then said, all right, okay, bring her up. And the thing is that her native heart actually supported her to the point where we were able to bring her back, replace the device, and get her through this. So that's the advantage with having an Lvad. If you have a total artificial heart, you don't have any backup. So it's not a great option. But in some patients, like patients who are transplant patients with failed transplants, then it's not an unreasonable option. So how do you select between all of these? And basically the way we select is really what's the purpose? And then we work our way backwards. So if it's somebody, is this somebody who needs lung support? Is this somebody who's going to need short-term support? Is it somebody who's going to need long-term support? Is it somebody who's going to need bridge transplant? And then we figure out which device is best for them, and then we figure out what we're going to put into and which spectrum of them. So that's really how we sort of look at it, and that's really what all the slide kind of tells you. This was the original HeartMate, and I'm going to show you, you're going to see this through the slides because all the slides that I have with the cartoons that illustrated were ones that I did with this particular device. So just bear with me, but again, the principles are the same. This was kind of what the original HeartMate looked like, and this is the problem with it. This is a young woman, she was 37 years old, also from Lvad, Wisconsin, who had a familial cardiomyopathy, came in cardiogenic shock, meaning that she wasn't pumping blood to her body adequately, and to the point where her kidneys were failing, her liver was failing. And I put this device in, and you can see it barely fits in her. And with this thing, you know, afterwards, she really couldn't eat very much because it's pushing on her stomach. Fortunately, she had been pregnant before, and one of the things with women who have been pregnant is their bellies are stretched out a little bit, so advantage to getting pregnant if you're thinking about it. And the device kind of was able to fit in her. This is actually after a heart transplant. Interestingly, she just sent me a box of fruit from Harry and David for Christmas this year with a card saying that this is her 10th anniversary, and she wanted to tell me that she had a wonderful life. And I've got to tell you, that's the best Christmas present I've had to date. I mean, it's really unbelievable hearing that. So the problem with this device was obviously it was too big, especially for smaller people. And that, but I'm going to walk you through how we put one of these devices in, because with a little variation, it's the same as what we're doing right now. So this is what it looks like in the cartoon. The patient's head is up here, the belly button's over here. We've opened the breastbone and we've opened the belly all the way down to the fat that sits outside the abdomen. And this is kind of cut sideways. See, the chitlins are all in here, and you can see that we're lifting up the muscle that sits above the abdomen where we're going to put the device. So this is what it looks like in the operating room. Head's over here, feet are down here. The sternum and the breastbone's been divided. The skin and muscle have been divided down to the fat just outside the abdomen. And we're raising the muscle off of the fat to create a pocket that we can put the device in. As I said, these devices were fairly large, so we had to make a fair amount of room for them. Then the next thing that you do is you sew to the tip of the heart. On the left ventricle, you sew this cuff it's a silastic cuff, basically a soft plastic cuff, and then you cut out the muscle in the center, and we're going to couple that with the inflow portion of the Lvad. So this is what it looks like. Basically, the silastic cuff sitting here, these are the stitches that are holding the cuff in place, and then we're going to stick the inflow portion of the ventricular assist device into that. So this is at transplant, and the heart's been opened, so you can see what the silastic cuff looks like and what the device would look like if it was resting inside, basically drawing blood out of the heart, held in place by that silastic cuff, goes into the pump. And then so basically it's sucking blood out of the left ventricle, going into the inflow cannula, into the pump, and then it's getting pumped up into the aorta, which goes like this all the way up in here. A couple of things with this that this illustrates. One of the problems with the left ventricular assist device is it only supports the left ventricle. So this sausage over here is the right ventricle, and it shouldn't look like that because the device doesn't support the right side. So that presents a problem in people that have what's called biventricular failure, where both the left and right side are failing. And sometimes we wind up, and I'll show you a slide, where we wind up having to put two devices in, at least temporarily. This is what the HeartMate 2 looks like. So there isn't such a big pocket. The head's over here, feet are down here. the pocket isn't as big, and you can see that this is, the apex of the heart is sitting here. The blood flows into the pump and then out through the outflow graft into the aorta. So this is a case where we've put in a left ventricular assist device, and then you had to put in a temporary right ventricular assist device, and the only ones that are available right now are these extracorporeal ones, the ones that sit outside. So you got one that sits inside the patient, one that sits outside, which gets to be a bit of a nightmare in terms of managing them. But these patients do remarkably well. This is Peter. Peter was was 37 at the time. He had a viral cardiomyopathy, and he was dying in the ICU. And this was around, must have been about 98, 99. And I don't know if you, for those of you who remember, the Rolling Stones had a concert, free concert in Central Park back in I think it was 99, so it must have been when it was. And Peter was he was a great, he had the gift of the gab, you know. So he goes down to Central Park and he manages to convince them that he should have front row tickets to watch this free Stones concert. So he's in there and his device malfunctions. So, you know, in those days there was actually a hand pump to these because they were pneumatic, and you always had to travel with a companion who would be able to hand pump it. So she hand pumps it, they get him back to Columbia. Turns out that those big magnets and the bass speakers fried the computer controller on this thing, and so we had to change out the controller. It took a lot of figuring it out. But again, those devices were bulkier, and we had two backups because we had his native heart. We also had a hand pump for these, which we don't have now. But it does highlight one of the issues with it. The controllers on the newer devices are much more robust. In the old days, you know, we'd have people with these with defibrillators in place, and if you put a magnet on it, it would affect the computer controller. So we would cover up the computer controller with a cast iron frying pan to shield it from the. I mean, it would do all sorts of bizarre things to make it work. Now, at least the computer controllers are more solid state and a bit more robust. All right. So that's putting.
Does it make the emergency physician in me less afraid now? I don't have to worry about getting a frying pan.
You don't have to worry about it. Exactly. Okay. So all strange. It's all strange things. You know. I'm gonna try and wrap things up by talking a little bit about purposes for doing this. But does anyone have any questions about any of the stuff we've covered so far? Otherwise, I can just go through it and then answer questions at the end.
Do you want to tell them about your batteries? He's had a lot of issues with the batteries with his in particular. And since that's all you have, you don't have any backup.
Right. Out of 8 batteries, 3 have gone bad twice.
Yeah. And it is a little bit of a, the batteries in general are pretty good. This is what, I'm going to pass this around the room so you guys can see what the ventricular assist device. This is a kind of marked loop. This end of it is the end that gets screwed into the inflow cannula. So this is the part that sits inside the heart. All right, and I want you guys, I'm going to pass it around because I want you to see it because it ties into the whole question of should you do CPR, because this is going to screw into this, and it's what's going to sit in the heart. This part screws into this, and this is what gets plugged into the aorta that pumps blood out. So I'm going to hand this out. This is the drive line. This part is all inside the skin, the velour part, and then the drive line actually comes out and is connected to an electrical cable. The electrical cable is connected to a computer controller, which is what this is, that basically controls it. It's got the alarms and devices off of it. And then there are 2 batteries for this particular device. Each of these devices will run for 12 hours. We don't recommend patients remove both of them at the same time. So the idea is you have one at a time that you change out as you need to. And each one runs for 12 hours. It comes with adapters to run off of your cigarette lighter in your car and at home. And so at night when you're sleeping, you're supposed to plug into the wall. And it's a hassle, but as Mr. Wilkie knows, it's a lot better than being dead. So, you know, it works. Yeah, exactly. So it is, again, it's a little bit of a huge lifestyle change that I tell people who are thinking about getting an assist device. It's a little bit like having your first kid. You know, gone are the days when you can just get up and go to the grocery store. All of a sudden you got to, where's my battery? Where's my, you know, diaper bags and thing. It's like having a first kid. You got to change your whole way of thinking. And you get used to them. I mean, we didn't throw our first kid out, so I guess it was all right. And like everything else, you sort of get used to these devices. Any other questions about the device itself? And we'll talk a little bit about reasons for putting them in. Yeah.
We've had a patient, well, we had someone from Tufts that had an Lvad implanted that lived here in the community. This was back in 2011. They sent us a couple things, and I was wondering if you have the ability to help us in this way. Number one, they gave us a hotline to call, and that if we have somebody who has an Lvad and calls EMS, there's a 24-hour nurse on call or professional staff on call, we can call. The second thing they did is they sent us a sheet of tips for taking care of somebody with an Lvad. Both designed for the first responding EMT who does not have ALS capacity, but also the paramedic. I don't know if you can give us some help in your considerations on that, because I know that we've been taught that if we have someone, the family members have received extensive training and listen to them. They will tell us what to do, but if there are any tips we can provide, either
Sure.
response or through a piece of paper that we can give to everybody and that to carry, that'll help us with the, you know, go beyond the understanding the role, but knowing what to do if we get into that moment where it's malfunctioning.
Right. I'll tell you, every Lvad program has a 24-hour line. So in the region, Albany Med and us at St. Peter's both have Lvad programs you can call. I don't want to speak for them, but I can. I mean, with every program, you can just call us to speak to the Lvad nurse. Certainly at St. Peter's, be happy to talk to you whether we put it in or not. And I mean, it's just like, doesn't really matter if we did the surgery or not. It's a patient, we'll take care of it. The second thing to remember, which is probably the most important thing, and it's the hardest for those of us who provide healthcare, is the best source of information and the best physician is the patient. They know the device better than even the doctor who put it in, because they live with it 24/7, 365. I mean, I've been doing this for 20 years, and I haven't even accumulated a hundredth of the life experience that Mr. Wilkie has, because I don't live with the device all the time. He can tell you why it's beeping and what it's beeping, and you have patients who come in and say it feels different, you know, and it's because then when we look at it, it turns out there's some clot on it, the vibrations are different, and you know, we're looking at it going, there's nothing wrong with this thing, there are no alarms going off, why are you saying it's feeling different? But they understand it. So usually the best resource is the patient. So my recommendation is to really ask the patient. They'll kind of tell you what's going on, and the family members usually will know what's going on. So that's your best immediate resource. You can call us anytime. Now, maybe I should just stop the talk here and we'll talk a little bit about sort of what to do in terms of resuscitation and so on. So there are a couple of things that can happen to the device, such as catastrophic failure. If the device fails, that pump is basically, I told you it's a screw that is spinning at high revolutions that allows the blood to flow. If the screw stops turning, blood can flow both ways, right? So blood can go from the aorta back into the ventricle and from the ventricle back into the aorta, which is why CPR is not very effective, because if every time you compress the heart, blood's going to go out into the aorta, then it's going to fill back again. So you're just basically going to be pumping blood back and forth into the upper aorta. You're not actually going to be getting systemic perfusion. The second problem you have is, as this thing comes around, take a look at that inflow cannula. It's a trocar sitting in the ventricle. So you do CPR on somebody with that, you're going to wind up actually causing a problem by ventricular perforation. The third part about it is from a system standpoint, there's not really much you can do to fix a down device. I mean, it's sort of it is why we, monitor these things, why they have the double batteries, and the computer systems, why we leave the ventricle in place to back it up. There's not a whole lot you can do. The best thing you can do is if the patient's in VFib, defibrillate them, and treat them as if they didn't have a device. So you volume resuscitate them. If you need to, you can start them on give them a shot of epi in the field, whatever it needs, as if they don't have a device. That's their best backup, is to get their own heart pumping as much as it can until you can get them to the hospital. So that's basically it. In terms of the device, you can't resuscitate it. On the other upside of the device is you can't break it either. They're pretty robust devices. And like, the example with the young girl who snapped her driveline, it was still kind of partially still working, even though she had broken half the cords in the driveline. So they're quite robust. Ms. Wilkie, any thoughts?
It would be easy to get it caught on something.
Yeah.
Definitely.
I've actually had a couple of those. I had another young lady who, sometimes people after pregnancy will develop what's called a postpartum cardiomyopathy, where their heart doesn't function. And she had one of these devices, and you can see it's fairly cumbersome, the controller. So she had a pickup truck, and she put the device on the console, drove to where she was, gets out, and after a while you get used to it, and she forgot it was in there and slammed the door in the driveline because she had left the console sitting. And so, it happens. The good news is she's living life, she's doing the things that she needs to do, and so that, we deal with it. But that's your most vulnerable part, is the driveline that comes out. The rest of the device is pretty robust. Anything else? You can defibrillate patients with the device in place. You're not going to, that thing howls at you like a banshee when the electrical system, when you shock it, but it actually doesn't stop it. It's not like the old frying pan days. It'll work right through it. But it does really howl, and it is very disconcerting noise that it makes, which is why I didn't plug it in, because it'll howl because it's not connected up. So, and it makes fire alarms seem pretty mild.
So for a basic life support provider, will a ventricular fibrillation be picked up by an AED?
Yes, it will.
Okay. But will we see a difference in measuring somebody's vital signs that has one of these?
So the hardest part with the vital signs is that, especially in the patients who are freshly post-op, is that they don't have an easy to measure systolic and diastolic because they've got continuous flow. They don't have a pulse per se. Over time, I told you the heart starts to recover, and as the heart starts to recover a little bit, it will eject every so often. And so you will see some pressure spikes, but you'll get odd pressures. So you'll get pressures like 90 over 60 or 90 over 80, your pulse pressure will be very narrow. And you'll be like, can I really hear it? Often you won't hear the diastolic. The only thing you'll hear is the systolic. And that's basically it. I mean, the best measure of, I don't mean to be funny about it, but it does sound kind of odd. The best measure of whether the device is working is the patient talking to you. It's even better than blood pressure, because they can't talk to you if they don't have a blood pressure. And that's really all you got sometimes, especially when you've got a device that's not functioning great, or the heart's not functioning great and it's not ejecting, so you're not getting that systolic that you can hear.
What about a pulse oximeter? Does that measure?
It won't, because sometimes it won't measure it won't see the pulsatile waveform. Now again, it really depends, because if you've got somebody who's got one of these devices, and I bet you right now you could measure blood pressure in Mr. Wilkie, just because I can tell. No? So, and again, depends on how bad his heart is. So
we take it at home, ultrasonic.
And that's it. There you go.
In the cup. So I want to know, do they carry them in their rigs?
The ultrasound? Do you guys have Dopplers? No. I mean, again, like I said, sometimes it all boils down to, are they talking to you? If they can talk to you, you know they're okay. The best you can do is get to a hospital, and that's it. On the other hand, there's not a lot you can do to break them either. So,
yeah. For Dr. Ushkow, from the emergency perspective, someone, if they have a radial pulse, you know that they have a BP,
80 and above is the
89,
answer.
right?
Yeah.
But
So-
I so much agree, even in the non-LVAD
Right.
patient. I mean, you were singing my song of stop looking at the numbers and the machinery and just look at the patient. And that will answer so much. And that you've heard me sing this song for years. This applies to an LVAD, this applies to somebody without an LVAD. Look at the patient, look at their coloring. How are they doing? Someone who is purple is not doing very well and they're hypoxic and they need oxygen. If they're nice and pink and they're chatting with you, I don't need to know the numbers, they're doing just fine. As an academic teaching attendant, when I'm wandering around and I'm watching the residents, I'm just looking in the doors and I know what room to walk in just by eyeballing the patient. I don't look at the monitor, I look at their face. That's it. So we don't really need the numbers, and is it gonna, the other question is it gonna change what we do in the pre-hospital world? You know, I am not Dr. Edwards, you are not Dr. Edwards, we're not gonna install this in the back of the rig. All we can do is give fluids, give oxygen, and give transport, which is a therapeutic option, right? So in this case, we can do all those things. Do I need a blood pressure to give oxygen, give fluids, and give transport? And the answer is no. And with that, just like stroke, just like STEMI, just like sepsis, early phone call. Early phone call to the hospital.
And like I said, both medical institutions have VAD programs, which means that both of them should have 20, well, I know we do, and I'm pretty sure Albany Med does have 24/7, 365 access to a VAD nurse. But they're going to tell you the same thing. Get them over to a hospital. In the hospital, really, the treatment is to start them on inotropes, see if you can get them to generate a blood pressure with their own heart. Because even if you have to go in and switch the device out, it isn't going to happen right away. You got to get the OR team in. You got to, I mean, between the re-op, the whole 9 yards, it's going to take a while. So you got to support them until that happens. So there's not a lot really that anybody can do until you can get them back to the operating room, which takes a little while. Yeah.
So in the local area, you said the two big hospitals are doing it. As EMTs, we're always concerned about where to take the patient, patient's choice. Do they go to a specific facility, or do they go to the facility where they had their surgery?
So the ideal is to take it to the facility where they had the surgery because they know them best. They also, with a lot of the patients, and I don't know about you, sir, but a lot of the patients are usually linked up with one of us. So a lot of times, they'll call us and say, hey, we did this guy, he lives in your area, they'll follow up with us half the time, and they'll follow up in Boston, New York, the other half of the time. So usually the patient will have a center that knows them to some extent. And if they don't know them, then either St. Peter's or Albany Med, whichever is nearer, and that's it. Don't stop on the way, because the last one I had, I was saying, was a lady who was in Rotterdam. She went into urgent care. They took her to St. Mary's, from St. Mary's to Ellis, and from Ellis to St. Peter's. It was like, oh my God, lucky this lady made it through all that, between all the,
So if they don't have an affiliation, the two big ones, and if they do,
Right.
to their affiliation?
Exactly.
Okay, thank you.
And if it's right outside St. Peter's, right outside Albany Med, and it belongs, just take them right to wherever's closest, and then we'll figure it out afterwards.
Can I add one other little piece to this too? We're talking about problems with the LVAD right now. You have to remember, most of the patient's problems aren't going to be LVAD related. They're going to be the poor guy going out to his mail, pick up his mail, he trips and falls and he breaks his hip. He just happens to have an LVAD.
Yep.
Still bring that patient to an LVAD hospital.
His affiliate, right.
Because what's going to happen is you're going to bring that broken hip to Memorial, who's going to say, they have an LVAD, yes, I could fix your hip, but not with the LVAD, they're going to get transferred. So
Yep.
for our location, for Bethlehem EMS, it's St. Peter's, Albany Med, you're done. Those are your two choices. Wherever the patient wants to go, they can pick between those two.
The best way to remember that, I'll tell you a story about a guy by the name of Garrett, he was a big, looked like a linebacker, African-American minister. And this was soon after 9/11. It was out in Fond du Lac, Wisconsin. So he goes in and he's got this device, with all this stuff in, and somebody sees the wires hanging out of his jacket and calls the bomb squad because they figure he's because they've never seen one of these things out in front. So that's why you don't want to really take him to a smaller hospital. Because and of course, Garrett was he was a rep. He basically played along. What are you talking about? Well, I don't know what do you mean? He had that poor police force up and down. It was, so if you don't remember it, that'll be a good story for you to remember it with. Yeah.
Gary's in particular, because his was installed in Boston. You're affiliated secondarily with St. Peter's?
Correct.
Gotcha.
Yeah.
Dr. Muller.
Yeah. So
Gotcha. So
Yeah.
most people that have it installed in
most
Saskatchewan are still going to have a local.
exactly. I mean, it's rare like that. The woman that we had, she just she had it put in Virginia and then just decided to move up here and didn't tell anybody. But that's unusual. I mean, most VAD patients are pretty, they're pretty savvy. They know what's going on. I mean, she is too, but there were other reasons why she moved up. But any other? Yeah.
About how many people live in the capital region at any given time between the two programs that would have a?
I would say probably around 20, because I think, I was trying to figure it out earlier. We were kind of talking about this, but between the two centers here and patients who have had it done in either in Albany, in Boston or New York, or even Rochester, there are a few patients around.
Do those centers generally reach out to the local EMS community, let them know?
They're not as good as they should be about reaching out. Most centers, when we started doing this, we would come in and literally do a whole training day for whatever the local systems were, and then we realized that really there was less and less that people could do. It was just more about making people comfortable with the idea that somebody has a device, so that they don't tend to do that as much. And instead, there's a tendency to prepare the patient and say, okay, this is what you need to know. This is where you need to go. If there's a problem, just tell them to drive you here, and then that's it. Because the rest of it kind of depends on who's on. Have they been to the training? Have they not? But and again, like I said, there's not a whole lot you're going to be able to do with it. I mean, there's not a whole lot, quite honestly, that we can do with it until we get them to the operating room, and that's a while, because you've got to, get in there and take it out and do all that. So, anything else? Any other questions? Mr. Wilkie, any?
Are there any plans for St. Peter's or Albany Med to start installing the hardware?
The hardware, the problem with these things is it becomes an issue of the expense of it. And if you're doing a lot of them, you can afford to have a lot of different drivers and consoles. The problem is not that one is necessarily so much better than the other, but by the time you own all of these, one, the team isn't proficient with one device. Now they've got so many, they've got one of this and one of that, they're not proficient. And the second is that the expense for the institution goes up, which is quite expensive to put these devices in. So right now there's no real plans to do it, but there's sort of equivalent devices like the CentroMag, and which is sort of a smaller implant device, the HeartMate 2, things like that.
Well, the only reason why Boston has it because the surgeon brought it with them.
Yeah, it depends. Like when I was in Wisconsin, I was at the university there, and we had the hardware, we had HeartMate 2, we had the SynCardia, the total artificial heart. But it's an academic center, and we basically were the transplant center for the state of Wisconsin. So it's a little bit different setup and mindset.
But hardware is not a destination.
No. Hardware is actually, I think technically still only a 2-week bridge, but everyone uses it for longer than that.
2-week bridge?
Yeah, I think it's actually the approval is technically only for 2 weeks, because I don't think the FDA has done the full approval yet. They may have, but that's what it was.
It has been approved for only a bridge.
Yeah.
Not a destination.
Right.
And I can see why, actually.
Yeah. Why?
It's like buying a Yugo compared to a Cadillac.
Yeah. It is, and that's sort of what really the rest of the talk was about. Is really about when do you use these devices. And one of the problems is that if the patient's a transplant candidate, it's great because you can bridge them to transplant. If they're not a transplant candidate, there's nothing else. So then it becomes really what's better, and I've had patients who have said, I've had enough of living with this thing. I'm done. And then there are others who, they get used to it. They don't have whatever reason it works with them. And, I've had patients who are 5 years out with it.
We met a gentleman that had a HeartMate for 10 years.
Yeah, yeah.
Is there a local support group?
I don't know.
I mean, we had one of the longest surviving patients was in Texas, and this was when the original HeartMate was approved only as a bridge as well, and he refused to be transplanted. Every time they'd say there's a heart for you, he'd say I don't want it, I'm fine. And this went on for years. I mean, he was literally until I think they started to have some infection issues, and he eventually decided to be transplanted. So. Yeah.
What, and I don't know if this would be more a question for him, but what's the deciding factor on where a patient goes, or like why you would go to Boston over going down the road to St. Peter's or getting a HeartMate versus what you guys offer? Is that just personal choice or physician choice?
I think it's your cardiologist.
Yeah,
choice.
it's how you enter the stream. It's sort of if you went down to Poughkeepsie, you'd probably wind up in New York City to get one of these devices. So it depends on where you are. Sometimes it's an issue of comfort and, with what I don't want to go there. You guys have only done a few of these. I want to go somewhere. And so I think it's all about the patient. It's whatever they decide and whatever their comfort level is. So I don't think there's really a correct answer to it. I mean, there's no good, you shouldn't go here, you should go there. It's just whatever people are comfortable with. And we've had patients who've gone elsewhere, had their VADs, come back to us and said, we wish I had the VAD put in here, just because it's home, it's comfortable, their family can visit, it's easier. And now that they've been through it, they're like, I guess it was okay. And then we've had others who are happy that they've gone somewhere else. So it's okay. Yeah.
Are these patients pretty much limited to living near a Lvad hospital? I mean, you said that the main ones in New York are just...
There are patients actually, even in Lake Placid with these devices, who have, I know of at least one patient up there, and there may be two now, that had devices implanted at the University of Rochester that are living up in Lake Placid. So yeah, you can live quite far away. When we were in Wisconsin, we had patients, I don't know if you know how the state of Wisconsin is, but Madison, which is the capital, is closer to Chicago. And then there's the whole Wisconsin, and there's the UP, which is the Upper Peninsula of Michigan, which tended to come to Wisconsin for their care. And we were taking care of patients who lived in the UP, which is like, living in Alaska. It's like in the middle of nowhere. And so, yeah, people are pretty functional with this. I mean, I had patients that go out and chop their own firewood, and, it's
I'm just curious, I also ride in the Syracuse area.
Yeah.
If you ran into a patient with Lvad, I mean, do you have to take him to Rochester or something?
If you're in the Syracuse area, you'd go to Rochester. That's probably the nearest center there. I don't think any of the Syracuse, in fact, I'm pretty sure none of the Syracuse hospitals have VAD programs right now.
Yeah. So, I mean, at that point, we were just talking before, what
Yeah.
you do, I mean, if you have to drive 2 hours.
Probably the easiest thing to do is to talk to the local emergency room. First talk to the VAD center, see what they recommend, and then talk to the local emergency room, because they can probably put them on inotropes, stabilize them a little bit more, and then retransport.
What we do is we would stabilize them, we'd fly them. You're going to ground transport.
Yeah.
We're going to put them in the air and go.
Any other questions for me? All right.
So if you could just run through, show us your device, wouldn't mind standing up for a minute?
Sure.
And
I brought the extra controller because they recommend.
We never leave home without it,
well,
until we do.
We're mostly never leave home with it. That's the controller. Basically, that's one of the two batteries.
show us how to say that you're semi-conscious saying, I need my battery switched, change out my battery.
It's
Show
a twist lock. So basically, you just twist it counterclockwise and then pull it out. And then when it goes in, it snaps. When I was talking before, if you look at the size of the drive line on that compared to the drive line on this, you know, the difference between the Yugo and the Cadillac. This was, the outer shell of the drive line broke. This is a patch that they did, and then it broke again, and this is a patch that I did. So,
All right. So, and you got 2 batteries on right now?
correct. I got 2
All right.
batteries.
So if we have to help you change a battery, the other one is, both batteries are always on, they're not in
No,
series, they're parallel? You have to turn one on and off?
Right, it draws on one. You always have to have 2 sources of power.
Okay.
All right, it draws on one and then it switches. The minute it switches, it goes into alarm. And this one's probably getting ready to go into alarm now.
All right.
All right, if you're plugged into AC power, you still have to have the second battery plugged in. You can plug in, I plug in at night, so.
That was going to be my next question to you. So we're going to bring you to the hospital from your house. We're going to take you off your battery power, and we have power in the ambulance. So what do we need to do to help you plug yourself in to run off our ambulance power?
I don't have a DC power cord, other than the batteries.
But your rigs have AC in them.
We have
right?
AC.
So that you plug into the,
We can just use your regular home device.
Right.
Yeah.
So basically, it's the same thing. It's a twist lock. It's a twist lock. And then you can see on this, you can see the line and the little dot on the controller. And then you line those up and push it in and it snaps.
All right. So it's really just that simple for us, guys. It's simply doing a connection.
Well, we have a resident expert. Actually,
two
go
things
ahead.
I want to say. He's always with a trained person, me.
You can fix
Almost
that.
always. He's rarely alone. The more likely scenario is going to be, he can change his batteries. It's going to be the drive line. That is, he's got about a minute, they're telling us, between 1 and 2 minutes, you never really know.
Before I pass out.
Before he can't change that, that would be where you would need to be trained on that device. But he's the only one in the area with that. So you guys from Ravina, that'd be
In that-
excellent.
That's why I ask about the
Yeah.
hardware, because I don't think there's very many patients with hardware.
There aren't a lot of hardware patients around. I mean, I worked with like I said, we use the hardware as well. It's a good device in terms of size, but it, like each of these things, you trade one thing up for another. I mean, this has a little bit more robust driveline, but then it's,
Yeah.
so it's like there's no good answer to it other than transplanting patients, and that's what you kind of wind up doing.
If we came across you and you were passed out, where would your second drive line be?
It would be in that black bag.
Okay,
Right.
so it would be
Right
in
there.
what, your duffel bag, whatever your medical
My man
is?
bag, yeah.
Okay.
Yeah, and this will tell you what's the matter. On him, you press a light, it tells you. It has an LED readout. What is the problem? It'll tell you if it's a pump failure. You'll know if it's a pump failure because you won't even get out of your rig before you hear the alarm. It's that loud.
Yeah.
But that's, am I right?
Yeah.
That's so very, very, very rare that it's a pump failure. Most often it's going to be a controller failure. And we have a saying in our family, it's not if the controller failed, it's when, because everything else has failed. So this is going to fail too. So that would be when we would engage paramedics, not for battery issues. But if we were transporting him for any reason, we would also need the wall plug because nobody in the area has a wall plug. So it looks like it has a transformer and one goes into the wall and one goes into him. It's really long.
Right.
So
we
I
could
would
use
say
that in
anybody
our
that,
ambulance.
right, that was the answer to the question. You have to bring your wall plug.
And in general, what we've found is sometimes you'll have a defective, as you've actually said, you'll have a defective battery. So sometimes the device will cause malfunction or when you've got it in battery, but when you hook it up to the wall unit, you won't get the malfunction. So that's
Right.
and very often the patient will tell you that because they're like, well, every time I go to my power, switch my power source, the thing starts beeping at me, and they'll, so.
But I split wood, I ride motorcycle, quads, I do, the only thing I can't do is swim. Everything else I wouldn't be afraid of doing.
How do you feel now?
Better than I have in years.
How many years?
I
have you
was
had?
really sick the last year.
So you have your aerobic ability to walk, you can,
I split firewood with an 8-pound maul. You know, basically, I do everything that I could do, you know, 10 years ago.
Keep Miss Jackie happy.
Right. I was told, listen, I was
Gio,
told that I
don't
can't
go there.
mention that, all right? So I'll only say 2 things, all right? Number 1, I've never had to take any, you know, kind of supplements. And number 2, it's never lasted 4 hours, all right? So.
she's died.
I'm going to actually divide this up a little bit for Dr. Edwards, so don't run away. I'm going to have more for you. Any other questions for Dr. Edwards since he has to go to the hospital and operate on somebody in the next half hour? Dr. Edwards, thank you very much for coming. Can you bring the microphone back?
Correct. Basically, it goes through the side.
Yeah, so there's no change in that drive line. That splits where you patched it.
There's 4 wires in there, basically, so you got to carry tiny little wire nuts,
Gotcha.
right?
Yeah.
Basically.
So
that's-
really, it would be a little bit of an electrician job, is rewire that thing and put it together. If that's what you had to do, you gotta do it.
It's out tonight, but usually I bring it up like that and tape it on my stomach so I don't get it caught on
People
anything.
can see that. I want people to see that things can travel through skin. And
You're gonna
You're
see,
gonna-
I give him Lovenox shots. The bruises are not from domestic
It's,
violence.
I don't feel safe at home, and you'll see why.
Why? No. Been through a lot.
That basically goes through, and then the pump is sewn in the bottom of the heart.
everyone see the bruises that she's talked about that you said was Lovat?
Lovenox.
Yeah, could we
Yeah.
talk about that a little? Why do you need Lovenox?
That patients have to have, they have an INR range that they need to be in. And if their INR is not appropriate, all of them are on anticoagulants. I'm sure the doctor would say that if he was talking. So if, for instance, his INR goes low, then he has to take Lovenox shots.
So what that means from an EMS perspective, okay, so here's your story. A person has an Lvad, he slips and falls. What's your prime concern?
He's gonna bleed.
He's gonna bleed, his Lvad's gonna be fine. Problem is, he's gonna have a head bleed, all right? That is gonna be the issue, and that's gonna be our approach. One of the things I wanted to get across in tonight's educational process is that your LVAD problems aren't going to be the LVAD. Your LVAD problems are going to be something else, along with complications like they're on multiple injections. Are you just on Lovenox, or are you on
Yeah,
triples?
3,
No, I'm on,
You're on triples?
4. He's supposed to be on 4 when he doesn't tolerate. So could I
Great.
interject, not to take over?
Yeah, go right ahead. You had
But
to.
for our perspective, we want you to know, and I'm sure all the other patients have a binder. We're at Mass General, so this is what they give us. And in here, you can, if, for instance, he was alone and you showed up, there's going to be a binder somewhere. And it's going to have his meds. It's going to have, well, I have what his INR is, what I'm giving him for Coumadin, what his blood pressure is, what his readings are. That tells you a lot. When you start looking at the readings and they're nowhere near here, then you know you got a big issue with the heart itself. I know if he's not talking, obviously. And then there's a med list as well. So if I were in your shoes showing up and the patient was in bad shape, I'd want this binder, because if they're doing the support person is doing her job, it's kept up to date. I'm not doing my job. Just to tell you that. There's a binder, look for it.
Okay.
Oh, that's great.
Do you have a palpable pulse or no?
No,
You have no palpable pulse.
no. I had my right side of my heart died also, so I had the dual pump. Yeah, I had, the right was the external after they did put the left in. And so, you know, basically I was an hour or 2 from death by the time I got to Boston. So it's only a miracle that I survived, basically. So my heart has not, it's recovered some, but not a whole lot. Without the pump, you know, so I don't have a pulse.
So we take it with Doppler.
So if the computer dies, lay you flat, put your feet up, pump as much fluid into you as we can, and beat the feet to the hospital.
Okay. For today, it'll be dopamine. For those of you who are ALS, for today it's dopamine, and the new protocols roll out, it'll be Lvad. Those are what you'll do. So, but from a VLS viewpoint, oxygen, 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 right? The whole purpose of the heart is to pump the blood to carry, and we have the ability to give a lot extra, right? Each red blood cell in a normal day is only carrying half the amount it can. So you can actually double it by putting them on a non-rebreather.
So for all the AAAs, we never lay them flat. For Lvad, we lay them flat and invert.
Correct.
Okay, thank you.
This may be a goofy question. Do you have a medical alert bracelet?
No.
Can't you see
In my
it?
wallet I have.
No,
I have a card in my wallet.
You have a card in your wallet?
Yeah.
Okay. The only reason why I ask that is because she may not be, for whatever reason, she may not be next to him for something, and someone may show up and go, what the hell is that? And he may be incapacitated to go, I have an Lvad, and explain what's going on. And short of going, oh, it's a medical alert bracelet. He's got an okay, I know what's going on. So,
So is it safe to say you also have a generator at your house, probably?
Oh, yeah.
Anything else, Robert?
No, I'm good. You guys have any other questions? Thank you very much to both of you for coming. We really appreciate it.